I want to start today with a bean.
A bean. Usually we start with a patient case or, a statistical
I
crisis.
know, I know. But I was reading through the historical contest in Goodman and Gilman, and I just got stuck on this one story. It's about this specific red bean from West Africa.
Ah, okay. Physostigma venenosum.
That's the one. Apparently, for a very long time, it wasn't really used as food. It was used as a judge.
You're talking about the trial by ordeal.
Exactly. The text describes how the Efik people of Old Calabar used this. If you were accused of witchcraft, and that's a pretty serious charge.
That's about as serious as it gets.
Right. There wasn't a jury selection or a defense attorney. They just made you eat this bean.
It sounds completely barbaric, but from a pharmacological perspective, it is fascinating. Because the outcome, life or death, it wasn't random at all.
That's the absolutely wild part. The lore was that if you were innocent, you'd survive. If you were guilty, you'd die. Simple as that. But when you look at the chemistry, survival seemed to depend entirely on how fast you ate it.
It's a lesson in kinetics, really. First-pass metabolism, absorption rates, all of that.
So if the accused person was terrified and they ate the beans really slowly, just tentatively.
The poison would absorb gradually.
Yeah, and it would paralyze their breathing and they'd die. So verdict. Guilty. But if they were confident, or maybe they were just hungry, who knows, and they swallowed a huge handful all at once.
The massive dose would act as a local irritant.
It would hit the stomach lining so hard and so fast that they would just vomit everything up.
Before the lethal dose could ever hit the bloodstream, they survived.
Verdict. Innocent.
So your judicial innocence was basically a function of your gag reflex.
Pretty grim way to put it, but yeah, accurate. And that bean, the Calabar bean, it contained the blueprint for this entire class of drugs we're diving into today.
It contained physostigmine.
Which brings us to our topic. We are looking at anticholinesterase agents. And the title of this deep dive is Prolonging the Signal.
It's a perfect description. I mean, in previous conversations, we've talked a lot about agonist drugs that act like a key fitting into a lock to open a door.
Right. They start the signal.
This is not that. These drugs don't touch the lock. They don't even touch the door.
They tackle the guy who's trying to close the door.
Exactly. They act on the cleanup crew. We're talking about inhibiting a specific enzyme called acetylcholinesterase, or ACE for short.
And I think it's important we set the stage with our sources here because we're really weaving two very distinct threads together for you. We have Kat Sung, specifically the chapter on cholinesterase activating and cholinesterase inhibiting agents.
And that's giving us the clinical scaffolding, the diseases, the doses, the side effects, the what to do.
And we are pairing that with Goodman and Gilman, particularly their chapter on anticholinesterase agents.
And that's where we get the heavy molecular lifting, the why it works, the kinetics of the enzyme, the chemical bonding, and this really terrifying concept they introduced called aging.
Aging sounds innocent enough, like a fine wine or a good cheese, but I have a feeling you're going to tell me it's not.
It's definitely not about wine. It's about a chemical bond becoming permanent, irreversible.
Okay, so let's get into the mechanism. To understand how we can prolong the signal, we first have to really understand the signal itself. We're talking about acetylcholine.
Right. Acetylcholine, or acetylcholine, is the primary neurotransmitter for a huge chunk of your body. It's fundamental.
So it's driving your skeletal muscles when you walk.
Yes, and it's slowing your heart when you rest. It makes you sweat. It helps you pee, and it's absolutely critical for forming memories in your brain.
But the body seems to have this love-hate relationship with it. It goes to all the trouble of making it and releasing it, but then it destroys it almost instantly.
It has to.
Yeah.
Think about a light switch. For that switch to be useful, you need to be able to flip it on, sure, but you also need to be able to flip it off immediately.
So you can flip it on again.
Precisely. If you flip the switch and it gets stuck in the on position,
you lose control. The signal just becomes noise, a constant hum.
Exactly. In the nervous system, especially at a place like the neuromuscular junction where your nerves talk to your muscles, you need distinct, crisp signals. Fire, stop, fire, stop. To achieve that stop, nature created acetylcholinesterase.
The vacuum cleaner.
I like to think of it more as a shredder, a high-speed molecular shredder. And Goodman and Gilman describes the structure of this enzyme in just incredible detail. It's not just a blob.
Right. It has a very specific geography. It talks about an active center gorge.
It's gorge, like a canyon.
Molecular canyon, yeah. About 20 angstroms deep. And the active site, the part that actually does the chopping, is buried at the bottom of this gorge.
which at first seems inefficient. Why bury it? Why not have it right on the surface where it's easy for acetylcholine to reach?
It's all about guidance and speed. The walls of this gorge are lined with aromatic amino acids, and they act like a guidance system. They create this kind of electrostatic pull that literally sucks the positively charged acetylcholine molecule down into the pit.
So it's a trap. It's a high-speed processing trap. This is one of the most efficient enzymes known to exist in biology. I mean, the turnover rate is staggering.
How fast are we talking?
A single molecule of ACE can chop up thousands, literally thousands of acetylcholine molecules per second.
Wow. So under normal conditions, acetylcholine is released from the nerve, it crosses the synapse, it hits its receptor, and then zip, it gets sucked into the gorge and shredded.
In microseconds. The signal is terminated almost as soon as it begins.
So when we use an anticholinesterase drug, whether it's the poison in that calabar bean or a modern medicine, we are essentially just blocking that gorge.
We are gumming up the works. We introduce a molecule that goes down into that canyon and just refuses to leave in a timely manner.
And because the shredder is jammed, the acetylcholine starts to pile up outside in the synapse.
Accumulation. That is the key word here. The drug isn't stimulating the receptor. The drug is causing your own acetylcholine to accumulate.
So it's turning up the volume on the body's natural conversation.
Exactly. Which means, and this was a big click moment for me while reading Katsung, these drugs only work if there is a signal to amplify in the first place.
Right. If the nerve is severed and no acetylcholine is being released, these drugs will do absolutely nothing.
You can't amplify silence.
Okay, so we've got the target, the gorge of the enzyme. Now let's talk about the weapons we use to attack it. The texts seem to break these down into 3 distinct classes based on their chemistry.
And how they interact with that enzyme.
Right. I like to think of them as the flirt, the sticky guest, and the bear trap.
Okay, I'm intrigued. I assume the flirt is the alcohol group.
That's edrophonium.
Edrophonium is the prototype for the really short-acting agents. It enters the gorge, it binds to the active site using very weak forces. We're talking hydrogen bonds, electrostatic interactions.
So not a real commitment, like holding hands.
Exactly. It occupies the enzyme, it prevents acetylcholine from getting in for a moment, but the bond is just very unstable. It breaks easily, the edrophonium just wanders off, and the enzyme is right back to work.
And the duration reflects that, right? It's incredibly short.
Minutes. 5 to 15 minutes, usually.
Yeah.
It's cleared by the kidneys very, very quickly.
So clinically, what is the point of a drug that only works for 10 minutes? I mean, you can't treat a chronic disease with something like that.
You don't. You use it for answers, not for long-term treatment. Edrophonium is primarily a diagnostic tool. We'll talk about myasthenia gravis in a bit, but basically, if you have a patient who is weak, and you want to know why they're weak,
you give them a shot of this.
You do. It's called the Tensilon test.
Tensilon being the brand name.
Right. And if they suddenly get dramatically stronger, you know the mechanism works. You think, aha, blocking this enzyme helps this patient.
And because it wears off in 10 minutes, if you were wrong or if they have a bad reaction to it, the problem solves itself very quickly.
It's a low-commitment diagnostic.
The flirt. Okay, now let's move to the sticky guest, the carbaments.
Now we're getting into actual therapy. These are drugs like neostigmine, pyridostigmine, and of course our friend from the bean, physostigmine.
How is their chemistry different from edrophonium? What makes them sticky?
They are what Goodman and Gilman calls hemisubstrate blockers.
Hemisubstrate. Okay, break that down for me.
So the enzyme, ACE, looks at a carbamate molecule and it thinks, food. It mistakes it for acetylcholine.
So it takes the bait.
It takes the bait, it pulls it into the gorge, and it actually starts the chemical reaction to break it down, just like it would with acetylcholine.
Okay.
It snaps, the bond hydrolysis happens, but then it gets stuck. The breakdown product, this carbamoyl group, doesn't leave the active site immediately. The enzyme becomes carbamoylated.
So it's like trying to chew on a piece of really, really sticky toffee. It can't open its mouth for the next bite.
That's a perfect analogy. And it takes a while to clear that sticky mess. While acetylcholine is processed in microseconds, a carbamoylated enzyme takes anywhere from 30 minutes to maybe 6 hours to reset itself.
Which gives us a duration of action that actually makes sense for a pill.
Yeah.
You can take it 3 or 4 times a day and maintain a therapeutic effect.
Exactly. This is the workhorse class for clinical treatment.
But within this class, the sticky guest, there's a huge distinction we need to make. It's really a lesson in geography. Katsung highlights this by comparing physostigmine and neostigmine.
And this is one of the most important concepts in all of pharmacology, lipid solubility. It determines where a drug can and cannot go in the body,
So physostigmine, the natural one from the calabar bean, is a tertiary amine.
which for our purposes means it is uncharged at physiological pH. It's oily, it's lipophilic, it loves fat.
And your brain is protected by the blood-brain barrier, which is essentially a wall of fat, a very selective gatekeeper.
So physostigmine can just walk right through that wall. It easily enters the central nervous system. If you give a patient physostigmine, you are amplifying acetylcholine in their muscles, their heart, their gut, and in their brain.
Now, you compare that to neostigmine,
Neostigmine is a synthetic compound. It's a quaternary ammonium.
quaternary, meaning it has 4 attachments to its nitrogen atom.
Yes, and crucially, because of that fourth attachment, it carries a permanent positive charge. It is polar, like water.
And oil and water don't mix.
Right. So neostigmine basically just bounces off the blood-brain barrier. It cannot get into the brain to any significant extent.
So its effects are confined to the periphery.
Exactly. The neuromuscular junction, the bladder, the intestines,
Mhm.
it stays outside the central compartment.
This might sound like a limitation, but in reality, it's a feature, right? It's drug design.
It's a huge feature. Think about it. If I want to treat your weak leg muscles, like in myasthenia gravis, I probably don't want to be messing with your brain chemistry at the same time.
You don't want to cause confusion or anxiety or nightmares as a side effect.
Exactly. So I choose neostigmine, the one that stays in the periphery. But if I want to treat something in the brain like Alzheimer's disease, or maybe an overdose of an anticholinergic drug that's causing hallucinations,
Then I need the one that can cross the wall. I need physostigmine.
geography dictates the drug choice. It's a fundamental principle.
Okay, that brings us to the third class. The nightmare class, the bear trap, the organophosphates.
These are the heavy hitters. And this group includes a few medicines like ecothiopate, which is used for glaucoma, but mostly we know them as pesticides like malathion and parathion and chemical warfare nerve agents.
Sarin, soman, VX.
Exactly, the most toxic chemicals ever created.
So what makes them a bear trap?
The bond. When an organophosphate enters the gorge of the enzyme, it phosphorylates the active site. It forms a full-blown covalent bond.
And a covalent bond is a strong bond. It's not like holding hands. This is a chemical weld.
It's extremely stable. In chemical terms, the half-life of hydrolysis is hundreds of hours. For all intents and purposes, the body has to just give up on that enzyme, destroy it, and build a new one from scratch to recover function.
Which takes days or weeks.
Right. But Goodman and Gilman introduces this really critical concept of aging here. And I admit, when I first saw aging, I thought it meant the drug got old on the shelf. But the text says the bond itself ages. It's a terrifying molecular event. Imagine you pour wet concrete into a hole.
Okay.
For a short period of time, that concrete is still wet. If you get in there fast enough with a shovel, or in our case, a chemical reactivator drug, an antidote, you can scoop it out and clear the hole.
You can save the enzyme.
You can. But after a certain amount of time, and this varies from minutes for some nerve gases to hours for others, a spontaneous chemical change happens. An alkyl group breaks off the inhibitor molecule while it is still attached to the enzyme.
A piece of the molecule just falls off.
It does. And when that piece falls off, the electronic structure of the bond shifts. It strengthens, it stabilizes. The concrete hardens instantly.
And once it's hard?
No shovel in the world can move it. The enzyme is permanently, irreversibly dead. That process is aging.
And this creates a frantic race against time. If someone is poisoned with the nerve agent soman, and the aging time is, say, 10 minutes.
You have 10 minutes from the time of exposure to give the antidote.
Yeah.
After that, you are just providing supportive care life support and waiting for the body to synthesize brand new enzymes.
That is incredibly high stakes. So we have the chemistry down, the flirt, the sticky guest, and the bear trap. Now we need to look at what happens to the body when we actually use these.
Right, because remember, we're just amplifying the existing signal. So to predict the effects, all you have to do is ask, where is acetylcholine normally, and what does it do there?
Let's do a tour of the body then. Let's start with the eye.
Okay, in the eye, acetylcholine has two main jobs via muscarinic receptors. First, it contracts the sphincter muscle of the iris.
Which pulls the pupil closed, giving you miosis, pinpoint pupils.
And second, it contracts the ciliary muscle. That's the muscle that controls the shape of your lens for focusing.
So when it contracts, it makes the lens fatter for near vision.
Exactly. So if you get a dose of these drugs, either systemically or as an eye drop, you become locked in reading mode. Everything at a distance will be blurry. It's called a spasm of accommodation.
But we use this therapeutically for glaucoma. How does contracting a muscle lower the pressure inside the eyeball?
It's a plumbing mechanism. Open-angle glaucoma is usually a drainage problem. The aqueous humor, the fluid in the front part of the eye, can't get out through its drain, which is called the trabecular meshwork.
But the pressure builds up.
Right. When you contract the ciliary muscle with one of these drugs, it physically pulls on that trabecular meshwork.
It pulls the plug open.
In a way, yes. It opens the pores of the meshwork, the fluid can drain out more easily, and the intraocular pressure drops. It's a mechanical solution.
Okay, let's move down to the gut and the urinary tract. This is the heartland of the rest and digest system.
Absolutely. Acetylcholine is the gas pedal for the gut. It increases tone, it increases motility and peristalsis, and it relaxes the sphincter so things can pass through.
So you can see the therapeutic use here. If you have a patient with paralytic ileus, say, their gut has gone to sleep after a big surgery and just refuses to move.
You can use a drug like neostigmine. It inhibits the enzyme. Acetylcholine piles up at the neuromuscular junctions in the gut wall, and it kickstarts the whole process.
Wakes the gut up.
Exactly.
Yeah.
And it's the same for the bladder. If a patient has urinary retention because the bladder muscle, the detrusor, is weak or atonic, neostigmine can help it squeeze.
But Katzing has a big, bold, red warning box here, a major contraindication.
You have to be absolutely 100% sure there is no mechanical obstruction.
Meaning if there's a tumor blocking the colon or a big kidney stone blocking the urethra.
And you give a drug that makes the smooth muscle behind that blockage squeeze violently. You will rupture the organ, you'll perforate the dowel, or blow a hole in the bladder. It's a surgical emergency.
So rule number 1. Check for plumbing blockages before you turn up the pressure. Now, let's talk about the heart. This part confused me a little bit when I was reading because the heart has input from both the sympathetic, the accelerator, and the parasympathetic, the brakes.
And acetylcholine is involved in both pathways, which is what makes it tricky.
Okay, so acetylcholine is the neurotransmitter for the vagus nerve, which is the main brake pedal on the heart. So more HE should slow the heart down.
Right. Bradycardia, that's the dominant parasympathetic effect.
But acetylcholine is also the neurotransmitter at the sympathetic ganglia, the little relay station for the accelerator pedal.
Correct. So you're amplifying the signal at both places.
So you're pressing the brake and priming the accelerator at the same time. Who wins that fight?
Under normal therapeutic conditions, the vagus wins. The direct parasympathetic brake on the heart is stronger. So generally these drugs cause bradycardia, a slow heart rate, and a decrease in cardiac output.
But I read that in severe toxicity, like with a pesticide poisoning, you might actually see a fast heart rate, tachycardia.
That's the twist. If a patient is poisoned, they might be severely hypoxic low on oxygen because their legs are failing.
Okay.
Hypoxia triggers a massive sympathetic panic response from the brain. In that messy real-world overdose scenario, the overwhelming sympathetic drive might temporarily overpower the vagus nerve, so you can see tachycardia. But pharmacologically, at the tissue level, expect slowing.
Got it. Now for the most critical system, especially for therapy and toxicity, the neuromuscular junction, the NMJ, the connection between nerve and skeletal muscle.
This is the primary target for treating myasthenia gravis, and it's the primary site of death in organophosphate toxicity.
The mechanism here is tricky because it's not linear. A little bit of the drug helps, but a lot of the drug hurts.
It's the Goldilocks principle. It's all about dose. At therapeutic doses, we prolong the life of acetylcholine just enough to get more receptor activation, which leads to a stronger, more sustained muscle contraction.
But at toxic doses,
You get so much acetylcholine flooding the synapse that the muscle membrane never gets a chance to reset. It can't repolarize.
it stays depolarized.
Right. And for a muscle fiber to fire a second time, it has to relax and reset its voltage. If the ion channel is held open by a constant flood of acetylcholine, the muscle becomes refractory. It stops listening to new signals.
So instead of a super strong contraction, you eventually get paralysis.
A depolarizing blockade. It usually starts with fasciculations. You can see these little ripples and twitches under the skin as individual muscle fibers fire chaotically, and then it progresses to a complete flaccid paralysis.
Which leads us perfectly into the big clinical disease here, myasthenia gravis.
Myasthenia gravis, or MG, is a classic autoimmune disorder. The body's own immune system produces antibodies that attack its nicotinic receptors on the muscle side of the NMJ.
So if we use a radio analogy, the signal is being sent from the nerve, but the radio itself doesn't have enough speakers to play the sound properly.
That's a great way to put it. You have fewer functional receptors, fewer ears to hear the signal. So normal amount of acetylcholine isn't enough to trigger a strong, sustained contraction.
and the patient gets weak. They present with drooping eyelids, which is called ptosis, maybe double vision, trouble swallowing, and they get tired just walking up a flight of stairs.
The weakness is typically worse with repetitive use.
So the strategy isn't to build new receptors. We can't really do that quickly with a drug. The strategy is to shout louder.
Exactly. We use an anticholinesterase like pyridostigmine or neostigmine.
Wow.
By blocking the cleanup crew, we let acetylcholine hang around longer and build up to higher concentrations in the synapse.
So even though there are fewer receptors, the ones that are still there get hit harder and more often.
It's a game of probability and concentration. We amplify the signal to compensate for the bad reception.
And Katsung mentions that neostigmine specifically has a little bonus effect here, too.
It does. Neostigmine's structure is similar enough to acetylcholine that it can actually bind directly to the nicotinic receptor and give it a little nudge, a slight direct agonist effect.
So you get the enzyme inhibition plus a little direct stimulation, a 2-for-1 deal.
It helps it, yes.
Now, managing these patients sounds incredibly stressful because of this thing called the crisis dilemma.
The myasthenic crisis versus the cholinergic crisis.
Yeah.
This is the nightmare scenario we hinted at earlier with the depolarizing blockade.
Let's play this out. A patient with a known diagnosis of myasthenia gravis comes into the ER. They are incredibly weak. They can barely breathe.
Okay, a critical situation.
There are two completely opposite possibilities. Possibility A, their disease is getting worse and they don't have enough medication on board. They're underdosed. That's a myasthenic crisis.
And the treatment for that is they need more drug. They need more signal amplification.
Right. But then there's possibility B. They accidentally took too much medication. They've overdosed themselves. Now their muscles are in that depolarizing blockade we just talked about. That's a cholinergic crisis.
And in that case, if you give them more drug, you will make them weaker. You could kill them. You need to stop the drug.
But both patients look exactly the same. They are both profoundly weak. They are both in respiratory distress. How on earth do you tell the difference?
You have to look for the wet versus the dry. You have to look beyond the skeletal muscles. Remember, the drug doesn't just work on muscles. It works on all the parasympathetic glands, too.
Okay, so the overdose patient, the one in cholinergic crisis, should be wet.
Yes. You look for the muscarinic side effects, meiosis, those pinpoint pupils. Are they salivating? Are they sweating? Do they have diarrhea? They're in rest and digest overdrive.
And the underdosed patient, the one in myasthenic crisis.
They should be relatively dry. Their pupils should be normal or even large, mydriasis, because of the stress and panic of not being able to breathe.
But physiology can be messy. What if you can't tell for sure?
That is where edrophonium, our flirt, comes back into play. The tensilon test.
It's a gamble.
A calculated one. You give a tiny, tiny test dose of edrophonium intravenously. If the patient suddenly gets stronger for a few minutes...
It was a myasthenic crisis. They needed more drug.
Exactly. And you give them their meds, but if they get even weaker...
It was a cholinergic crisis. You've just confirmed the overdose.
Right. But because edrophonium only lasts 5 or 10 minutes, the worsening is temporary. You support their breathing with a ventilator, which should be on standby. You wait for the edrophonium to wear off, and now you have your answer.
Still, that takes nerves of steel as a clinician.
It absolutely does.
Let's shift gears and move up to the brain. Alzheimer's disease.
The problem in Alzheimer's is a bit different. It's not about receptors on the target cells being destroyed. It's about the neurons that release the acetylcholine dying off.
So the source is disappearing.
Specifically, the cholinergic neurons that originate in a part of the brain called the nucleus basalis of Meynert and project throughout the cortex.
Oh, the wires are being cut. The signal is fading.
And that signal is critical for memory, for cognition, for attention. As those neurons die, the cognitive decline accelerates.
So the strategy is the same as in MG, conceptually.
Yeah.
Amplify whatever signal is left.
Precisely. We inhibit acetylcholinesterase in the central nervous system to make the most of the dwindling acetylcholine supply. But here, geography is everything. Neostigmine is useless for Alzheimer's.
Because it's charged, it won't get into the brain.
So we have to use lipid-soluble agents, drugs like dunpezil, rivastigmine, galantamine. These are all designed to cross the blood-brain barrier.
And what can the patient and their family expect from these drugs? Is this a cure?
No. And Goodman and Gilman is very clear on this. It's really important for managing expectations. These drugs are not disease-modifying. They do not stop the neurons from dying.
They just turn up the volume on the neurons that are still working.
That's all they do. It's a symptomatic treatment. It might improve cognition and function modestly for a time. It might give a family another 6 months or a year of better clarity with their loved one. But eventually, enough neurons die off that there is no signal left to amplify.
And the drugs stop working.
And the disease progresses.
That's heavy, but so important to understand. Okay, one last clinical use before we get to the full-blown toxicity case. Anesthesia.
Right. Reversal of neuromuscular blockade. This is a standard procedure in operating rooms every single day.
So when you have surgery, the anesthesiologist often paralyzes you intentionally. It keeps you from moving and makes it easier for the surgeon to work. They use drugs like rocuronium or vecuronium,
which are non-depolarizing blockers. They are competitive antagonists.
Think of them like putting gum in the lock. The key, acetylcholine, can't get in. The muscle can't contract.
Exactly.
So the surgery ends. You want to wake the patient up and have them breathe on their own. The lock is still gummed up. What do?
You give neostigmine. You inhibit the enzyme. And suddenly, the synapse just floods with acetylcholine.
And it becomes a numbers game.
It's the law of mass action. If you have millions and millions of acetylcholine molecules, they will physically shove the blocker molecules out of the way just by sheer numbers.
They outcompete the blocker.
They reclaim the receptor, the muscle starts firing again, and the patient wakes up and can breathe.
It's basically just crowding out the blocker with the body's own neurotransmitter.
That's exactly what it is.
Yeah. Okay, we have covered the therapy. Now we have to cover the tragedy. Toxicity. And Katzun gives us a specific case study to walk through. JM, the 43-year-old farmer.
This is a classic textbook presentation. JM was in his field spraying a sulfur-smelling material.
Let's pause right there. That sulfur smell is a huge giveaway.
It is characteristic of certain thiophosphate insecticides, like parathion or malathion. They're converted in the body to their active oxygen-containing forms, but the parent compound has that smell. He's been exposed to an organophosphate.
And he didn't drink it. He was spraying it.
These compounds are highly lipid-soluble. They absorb right through the skin. They're absorbed through the lungs if you inhale the mist. JM was probably not wearing adequate protective gear.
So he comes into the clinic. He's agitated. His gait is unsteady. He's having trouble swallowing. His vision is blurred, and he has chest tightness. Let's break those symptoms down. The mnemonic everyone learns for this is dumbbells.
Or SOL-DDE. They both capture the same muscarinic excess. Dumbbells stands for diarrhea, urination, meiosis.
Blurred vision and pinpoint pupils. Check.
Bronchospasm and bronchorrhea.
Chest tightness. Check.
Excitation of skeletal muscle in the CNS.
Yeah.
Followed by paralysis. Emesis, which is vomiting. Lacrimation or tearing. And salivation and sweating.
It is an incredibly wet picture. It's basically liquid coming out of every possible orifice.
It is. But the most acutely life-threatening parts were the B and the E in dumbbells.
The bronchospasm.
JM's chest tightness isn't a heart attack. It's the smooth muscle in his airways constricting violently. At the same exact time, the glands in his lungs are hypersecreting mucus and fluid. Bronchorrhea.
So he is drowning in his own secretions while his airway is clamping shut.
It's a terrifying combination. And then you add the E, excitation and paralysis.
That's the nicotinic effect of the muscle. JM had an unsteady gait.
Initially, the muscles twitch and fasciculate, but that progresses to the depolarizing blockade we discussed. Flaccid paralysis.
Yeah.
And if your diaphragm, your main breathing muscle, becomes paralyzed while your lungs are filling with fluid.
That is the primary mechanism of death.
Right.
Respiratory failure.
A combination of central respiratory depression, airway obstruction from secretions, bronchospasm, and diaphragmatic paralysis. It's a multi-front assault on breathing.
So JM is in very serious trouble. How do we save his life? Step 1.
Decontamination. You have to get his clothes off immediately and wash his skin with soap and water. If you don't, the poison just keeps absorbing and no amount of antidote will keep up.
Step 2. The antidotes. Plural. We have 2, and they do very different things. First up is atropine.
Atropine is a muscarinic antagonist. It goes to all those muscarinic receptors in the gut, the bladder, the salivary glands, the heart, the lungs, and it blocks them. It's a competitive antagonist.
So it dries them up.
It dries them up completely. It stops the salivation, it stops the sweating, it opens the airways, it fixes the slow heart rate. It is absolutely life-saving for the muscarinic symptoms.
But, and this is always the big gotcha question on exams, does atropine fix the muscle paralysis?
No, it does not. Not one bit. Atropine only works on muscarinic receptors. The skeletal muscles use nicotinic receptors. Atropine does nothing for JM's weak legs, or, more importantly, his failing diaphragm.
So he could still stop breathing and die even if you've given him massive doses of atropine.
Correct. You have to be prepared to intubate him and put him on a ventilator. But there is a second drug for the muscle problem, pralidoxim, also called 2PM.
This is the chemical crowbar we talked about with the concrete.
That's what it is. Prolonging is a cholinesterase reactivator. It has a chemical structure with a super high affinity for the phosphorus atom in the organophosphate. It dives into the enzyme's gorge, it grabs onto the inhibitor, and it physically pulls it off the enzyme.
It regenerates the enzyme.
If it works, yes, the enzyme is restored. It starts chewing up acetylcholine again, the concentration in the synapse drops, and the paralysis resolves.
But there's that big catch again, the concept of aging.
Yes. Prolonging only works if the concrete is still wet. If JM waits too long to come to the hospital, if he tries to sleep it off and comes in 2 days later, that chemical bond between the organophosphate and the enzyme may have aged.
The concrete has hardened.
And if it has aged, prolonging will just bounce right off. It can't break that strengthened bond. The treatment window is narrow, and it varies depending on the specific chemical.
There is also a quick mention in the texts of something called intermediate syndrome.
That's a strange and dangerous phenomenon.
Ah.
Some patients seem to recover from the acute crisis with treatment, but then 24 to 96 hours later, they develop a severe recurring weakness.
The same symptoms again?
Not exactly.
Yeah.
It specifically affects the neck flexors, the muscles that hold your head up, the proximal limb muscles, and the muscles of respiration. It can be a delayed onset respiratory failure. We don't fully understand it, but it's a trap for clinicians who think the patient is out of the woods.
This entire class of drugs, from the calabar being used in a trial by ordeal to the nerve gas on a battlefield, it really illustrates the razor's edge of pharmacology, doesn't it?
It really does. We are intervening in a system that is so fundamental to life. We're taking the body's off switch for a critical signal and, taping it over.
And sometimes that saves your sight in glaucoma, or it restores your strength in myasthenia gravis.
And sometimes, if the dose or the context is wrong, it paralyzes you in a field.
It's all about the balance. The amplification of the signal is an incredibly powerful tool, but the body has those cleanup crews for a very, very good reason.
To maintain control.
I think that's the perfect place to wrap up. We've gone from witchcraft trials to chemical warfare to Alzheimer's treatment, all by manipulating this one single enzyme.
The humble and incredibly efficient acetylcholinesterase.
For our listeners, if you want to see the clinical tables that compare neostigmine, pyridostigmine, and the others, or see the full list of symptoms for dumbbells, check out Kat Sung's chapter on the topic.
And for the really beautiful molecular graphics of the active center gorge, and to get into the nitty-gritty kinetics of aging, Goodman and Gilman's chapter on anticholinesterase agents is where you want to go.
This deep dive is your map, but the book is the territory. We really encourage you to go and explore it.
And maybe double-check the label on your gardening chemicals.
Thanks for listening. We'll catch you on the next deep dive.